Welcome, everybody. This is IBD Insider. It's patient updates from the 2021 Crohn's and Colitis Congress. I'm delighted that you've chosen to spend some time with us today. We know that we have many patients and family members of patients who have signed up to be with us during this incredible virtual program. My name is Dr. David Rubin. I'm chair of the Crohn's and Colitis Congress Organizing Committee, and I'm also the incoming chair of the Crohn's and Colitis Foundation's National Scientific Advisory Committee. I'll start that 3-year term in April. I am the chief of the section of gastroenterology and an IBD expert from the University of Chicago. Last week, we hosted the annual Crohn's and Colitis Congress. More than 1,400 IBD health professionals and researchers came together, representing over 35 countries to discuss the latest research about Crohn's disease and ulcerative colitis. Everything from basic science through clinical science to new treatments to discussions about wellness and health. It was an incredible meeting. It was the 4th year that we were doing this meeting, and it's a collaboration between the Crohn's and Colitis Foundation and the American Gastroenterological Association. This is the 2nd year that we're offering a special program summarizing these exciting updates for our patients and for their family members, and we're delighted that you have chosen to be with us today. Today, we're taking the information that was presented at the Congress and bringing it to you during this IBD Insider program so that you'll have the most up-to-date understanding of your condition. I want you to remember that every person with Crohn's disease and ulcerative colitis has a unique set of characteristics that are unique to their disease, location, its behavior, but also to the individual components of how your symptoms manifest, how you respond or don't respond to certain therapies, and what might be right for you. The purpose of today is not just to tell you and teach you about advances in science, which are incredible, but also to empower you so you have knowledge about your specific condition and you understand how to take control of the disease and live a higher quality of life. This is the time when we have more treatments than ever. We've learned more about holistic and broad multidisciplinary approaches to managing inflammatory bowel disease. And I want one of the main takeaway messages for all of you to be today that you can control your disease, you can ask the right questions, you should be empowered to understand how to live a better life despite a diagnosis of Crohn's disease or ulcerative colitis. You're going to hear from patients and clinicians on a variety of topics, including how to get the most out of your healthcare visit, the future of treatments for inflammatory bowel disease, a broad spectrum of multidisciplinary discussions about IBD care and caring for the whole person, and of course, updates about COVID-19 and what we've learned about IBD and the vaccines. Obviously, this is not meant to replace the advice and recommendations of your doctor or your healthcare team, but to enhance your dialogue with them. Take notes, write down the questions you want to ask the next time you're with your doctor or your advanced practice nurse or your IBD specialist nurse. If you feel like you're unable to have that dialogue, we do encourage you to reach out for second opinions and to take control of your health. I want to thank the sponsor of today's program, Bristol Myers Squibb, as well, of course, to the patients, clinicians, and staff from the Crohn's and Colitis Foundation and the American Gastroenterological Association who worked so hard to put this together for you. I know it's going to be a great program. Now, it's truly my pleasure to introduce patient advocate and journalist Natalie Hayden to get the presentation started. Natalie has a Twitter feed, she has Instagram, and she maintains a very popular blog that I recommend called Lights, Camera, Crohn's. Natalie, take it away.
Thanks so much for that kind introduction, Dr. Rubin, and hello to everybody. My name is Natalie Hayden. I was diagnosed with Crohn's disease when I was 21 years old, 2 months after graduating from Marquette University. I was sent home on 22 pills a day, wondering where my life was going to take me, what this meant for my future. But I didn't let my disease stop me. 3 months after diagnosis, I moved 8 hours away from all family and friends and started my TV career as a journalist. And from there, I worked nearly 10 years in television. And once I left the news desk in 2014, I thought now is the time to share my story, to make a difference, to be the voice I so desperately needed to hear upon diagnosis. So that's when I started my advocacy journey, when I launched my blog in 2016. Now I'm married. I have a son named Reed who will be 4 next in March. And then I have a daughter, Sophia, who's 2. I'm also pregnant with my 3rd child, a baby boy due in July. So we're looking so forward to today's discussion to show you that you are so much more than your disease. Of course, IBD is a difficult, challenging illness, and it affects each of us in such unique ways, but there are ways to control it and to have a beautiful quality of life. As Dr. Rubin mentioned, we have a very engaging discussion today. We're looking forward to featuring fellow patient advocates and clinicians and talking about some really interesting topics that we think will all be of interest to you. The program will be recorded, so if you have to jump off or if you can't be on the whole time today, do not worry. You can check it out on the IBD Insider website later this week. And we want this to be as interactive and engaging for you as possible. As you're listening today, you can submit questions via Zoom, and we encourage you to do so. There's going to be a Q&A area in the lower part of your screen, and we're really excited about this. Anybody who submits a question is eligible for a $300 Amazon gift card, and we will be announcing the winner in the next week. So be sure to submit a question, whatever it may be, and we'll do our best to get it answered today. Well, I'm really excited to kick off today's program. Without further ado, I want to go ahead and invite our first panel of discussion. That's Dr. Rajiv Jain. He is a gastroenterologist with Texas Digestive Disease Consultants. Parsa Iran Mahboob, who was diagnosed with Crohn's at age 8. He's currently a student at UCLA, and he leads the National Council of College Leaders. Shaylin Feaster, she's out of New York City. She was diagnosed with Crohn's when she was 19. She's currently an auditor for a COVID contact tracing program. So she has a very unique perspective to share today. Our first discussion is about getting the most out of your IBD care. It can be so overwhelming and even intimidating to go to your doctor and not know what questions to ask, or maybe have your questions, but think, I don't know what I want to ask. So we're gonna go ahead and we are going to start the discussion with Dr. Jain, Parsa, and Shaylin. If you could all get on camera so we can start the discussion. Dr. Jain, what measures do physicians take to personalize treatment and make sure it's tailored to each patient?
Thank you, Natalie, and welcome to all the participants. What we do as physicians and providers to make sure that we've personalized the care is we try to look at both disease factors and patient factors. The disease factors that are most important are, how active is the patient's disease? What part of the bowel is involved? How severe is it? Are we trying to induce a remission, or is the patient stable? We want to take all those factors and put it together to try to come up with what might be the best medication for the patient, or medications, and sometimes even surgery. And we want to also put that in context of other medical issues that they may face. But I would tell you the most important thing to me, and I think all of our patients, is how are they doing, and what in context of the work, family situations, social situations, are they changing jobs, getting new insurance? I put all of those things into context and then work with the patient to figure out what are their goals and desires, and then try to synthesize that so that we can come up with best treatment.
Dr. Jain, I think a lot of patients have this question, but how do tests like endoscopies, blood tests, stool tests like calprotectin levels, and other types of tests and exams help us know if we are on the right track?
Parsa, that's a great question. We, look to the patient again to see how they're feeling. And that's the most important thing. But we all know that there's a disconnection often between how good or bad the patient might feel and what the inflammation is in the lining of the GI tract. And ideally, we want that GI tract to be normalized. So we can look at multiple things. We can look at scoring systems, which are used mostly in studies. But what really it boils down to is looking at markers of inflammation. Those can be from blood and stool tests. So one is called the fecal calprotectin, and we like to use that more in colonic disease because it is a true measure of inflammation in the GI tract, whereas some of the blood tests like CRP or ESR, those can be elevated from other reasons, and many patients, they won't go up. So those blood tests aren't always accurate. We can use imaging, for example, an MRI of the small intestine to look for inflammation in the GI tract. And then finally, procedures like endoscopy for folks that have upper GI involvement in Crohn's disease, but most often colonoscopy or flexible sigmoidoscopy to look for inflammation in the colon and rectum. Those tests put together with other diagnostic and predictive markers from scoring systems help us decide again what's going on with the patient and how we can work with the patient to get them feeling best and avoid future complications.
Well, there's so much that needs to be monitored when managing Crohn's disease and colitis. How can a patient work with their GI provider to ensure effective communication with other specialties in their health team, such as the intersection between GI and psychosocial needs, dietitians, primary care physicians?
Again, Parsa, a great question. I like to think of it in several buckets, if you will. One is the care setting that the patient is in. Are we talking about an outpatient situation or an inpatient situation where they're hospitalized? And the reason that is so important is that your options on who you're going to call and get involved in your care varies by that care setting. And then second, I like to think about is acuity. That is, how urgent, emergent is the situation, or is this something that is very elective and not in a time constraint? And that applies to both inpatient and outpatient settings. So again, talking to the patient, trying to figure out how urgent we need to do these things. And then finally, all of this comes down to communication, not just between the provider and the patient, but between the entire care team. And that may be the provider talking to another provider. And I like to tell my patients, you know what, do you mind if I pick up the phone right now and call so-and-so? Because so many times now we send an electronic message or a letter and everybody's inbox is just crazy. So I think it's critical when situations are important and you need to get the information across, is for providers and other folks on the team to communicate directly with each other. And then I think the biggest and most important thing I tell my patients, and I believe this, is to close the loop. That is, if I tell you, or you tell me you would like to see a dietitian, I need to make sure that you saw the dietitian and then I got the report back on how we're going to modify your diet to give you the best outcomes. And if there's no closing the loop, things can fall through the cracks, and I believe bad outcomes are more likely to occur. What's been challenging for you all when you have navigated your care? I wanted to see what tips you all might have to ensure that you're proactive in getting the care they need.
That's a really good question, Dr. Jan. I think as a new patient, the biggest struggle is not knowing how to navigate. What does the portal message mean when I get my lab results back and my numbers are high and low and I'm at work and I get these results and I'm petrified, what's going on with my liver, what's going on here, and there's no explanation. I also think one of the most challenging parts of the disease is how it blindsides you. You can feel perfectly well in the morning and be hospitalized at night. So I think kind of coping with how to even deal with this disease and never know what the next hour or the next day is going to bring is something that's very overwhelming for our community.
And some tips I could suggest for patients is to find out how your doctor prefers to communicate. A few years ago, I used to communicate via email with my doctor, but as Natalie mentioned, we do have the portal now through apps. You also still have the old-fashioned telephone. So I would suggest find out how your doctor likes to be contacted, and knowing the difference between an urgent situation and an emergency situation. So Dr. Jan, can you tell us a little bit about, can you clarify a bit the difference between an emergency situation and an urgent situation?
Absolutely. And first of all, if my answer to all my patients is, if you're not sure what's emergent or urgent, you know what? Call me. I'll help you figure it out. So I think that's the most important thing, is if you're not sure, always err on the side of assuming this is emergent and contact your provider. The most important way to contact providers if you think it's emergent. So for example, severe abdominal pain that's not improving, bleeding that just continues unabated, high fever, just something that doesn't seem right. And again, you know your body the best. So in those situations, always call the provider. Don't use electronic formats such as portals or email. Those things often are for non-urgent matters, and so they may not be checked as frequently. But when a practice gets a phone call, I'll tell you they'll respond. Other things I would say is, as we have on the slide, is getting prepared for your visit, writing your questions out, being honest and having an open communication. That goes both ways between the provider and the patient. And I think the more prepared the patient is in terms of reviewing their symptoms and previous studies, the less time the provider will spend trying to extract that information from the patient, and therefore spend more time addressing your questions, concerns in a very nuanced fashion. I think also, if we want to look at effective telemedicine visits, you want to know if it's going to be an audio visit or an audiovisual visit. You need to know ahead of time if that's going to be the case. Do you have a smartphone or a device that will allow you to connect? And do you have a good connection? You want to be in a space that is private, but there's good communication. Fill out all your paperwork ahead of time. Get that information there, again, just so that you don't get slowed down. And then, as I mentioned previously, I think the most important thing is for all of us to have an open dialogue with each other. We have to have trust in each other, and we have to earn it. But once we earn that trust, I think the relationship and the outcomes improve dramatically. As telemedicine has been growing, I would kind of ask the group, how have you been addressing these things? What have your experiences been?
I had personally never experienced telemedicine prior to the pandemic, and I actually prefer it. Being a mom with 2 little ones, it saves me a lot of time and energy not to have to get childcare and not have to commute and just sit in the comfort of my home. And I really felt like I was able to have a really great discussion with my GI, and I didn't feel rushed that there was a patient in the waiting room. So for me, it's been very positive.
I agree. I do appreciate the one-to-one with my doctor. I can do it on my lunch break. I don't have to miss work. And I can say it's one of the good things that did come out of the pandemic because a lot of insurance companies were not covering telemedicine prior to 2020.
And then I would just add really quickly that, yeah, I've enjoyed my televisits as well. And, I've made sure to have, as you mentioned, good connection and to know what device to use. I know my first visit, I used a computer and I wasn't able to actually get on. But I would also say, it kind of depends on the state of my disease. I think now that, unfortunately I've been in remission, I think a lot of that comfort is there of just, having that, casual conversation with your GI provider without necessarily being in the office.
Well, I want to thank all the participants. I want to close by just saying to everyone, please listen to the rest of this program. We're, I think, on the end of the time, so I'm going to skip this last slide. But I just want to tell everyone, please encourage you to talk to your providers, have an open dialogue, find the right treatment approach. We want to avoid steroids if we can. Use all the tools that are available to you through telemedicine or the offices. Ask questions and be proactive. Thank you very much.
That's great advice, Dr. Jan. Thank you so much. And thank you, Parsa and Shaylin. Now I'd like to welcome Dr. Bridget Boland. She's going to join me on a topic I think many of us are very interested in hearing about: future therapies and what's coming down the pipeline for the future for all of us patients. Thank you so much, Dr. Boland, for being here. And before we kick off this discussion, who did we hear from about this from the Crohn's and Colitis Congress?
Well, thank you so much, Natalie, and thank you to all the participants for joining us today. We're really excited to really be able to communicate with a lot of people at once. So, there's a lot of excitement right now in terms of what's coming in the pipeline. So there were a lot of different talks about this at Congress. 3 of them that we're sort of highlighting are Stephen Hanauer, Jean-Fred Colombel, and Marla Dubinsky, all talked about different aspects of future therapies and sort of where we're looking to go in the future.
When we speak of these future therapies, through the past few years, we've seen so many in the different news outlets, and it is very promising and exciting. But as we always discuss, the disease manifests so differently in each person, and not everybody responds to therapies. Unfortunately, with the therapies on the market right now, they only have 50% efficacy rate. So what is being done in the future treatments to try and shift that dial so we have more effectiveness and more people are able to reach remission?
Absolutely. So, I think what we currently have is not quite what we want. To take a step back for just a moment, I thought it'd be important to talk about the treat to target approach. And so, over time, we've learned more and more about what our goals of treatment for IBD should be. And previously, we thought treating symptoms was the ultimate goal, and it's still a huge goal. But what we've learned is that if we can heal ulcers in the lining of the intestine, as Dr. Jan referenced, that really actually leads to better outcomes. It can actually prevent complications like surgery, and really ultimately, we think, leads to better quality of life. So the goal is still to also treat symptoms, but kind of a more an even deeper goal to kind of help prevent problems in the future. So, to do that, basically the approach is, we start a therapy and then we want to see if it's working. And just like a rash, we almost want to, look at the lining of the intestine and see whether it's healed up. And if we haven't healed the intestine, we want to keep going, modify things. So that's the kind of treat to target approach. And as you mentioned, so where are we going with these new therapies? And there's a bunch of different, I think, things that the new therapies need to address. And just kind of breaking them down by different topics, there are kind of developing new therapies. So what's out there for people who haven't responded to anything? Let's find something that works in a totally different way. Next is, as you mentioned, our therapies aren't good enough right now. We're excited to have what we have, but we still have a long way to go. And we want to make these more effective and longer lasting. Another goal is really making them even more targeted. So less side effects, working exactly where we want them to work without the side effects. That's really also a big goal. And the last thing I think that is a big goal is really just making them more convenient. Injections, infusions, those aren't always, they're very useful, but, can be really hard, and for certain people harder than others. So trying to find pills, which are small molecules. And sort of thinking about what are these new targets or new therapies targeting? You have to think about what causes IBD, and it's complicated to say the least. And I think just thinking about a couple things that contribute, we know genes are, a little part of the story. We've learned a lot from them. The environment plays a big role. The bacteria in your gut, called your microbiome, plays a big role, and then the immune system plays a big role. So traditionally, most of our therapies actually targeted the immune system and kind of that overactive immune system that we think plays a big role in IBD. But what we're now getting is therapies that also target other things, like the microbiome. Can we shift this and change this to make disease better? And similarly, the environment, diet therapies are considered kind of part of your environment, as well as contribute to your microbiome. So there's kind of new things being targeted with our therapies now, which I think is really exciting.
And what are some of the emerging therapies we may expect, and how do these key classes of emerging therapies differ from what's available to patients right now?
That's a great question. So this is a lot of big words on the slide, but there's kind of, I think about the new emerging therapies in a couple different categories. The first thing I think about is there's sort of the version 2.0 therapies, the new improved. So maybe they're a little bit like some old therapies we have, but hopefully better. The first category, this is called the anti-trafficking antibodies. So the current one available is vedolizumab, or Entyvio, the way we more commonly know it. And so what these medications do is they prevent activated immune cells from getting to the GI tract. And so we're looking at kind of a couple other ways to do that, sort of very similar molecules, but work in slightly different ways. And they're also looking at how to use Entyvio as an injectable that you can use at home. So these are all kind of coming. The next category of version kind of 2.0 molecules that I think about are the anti-interleukin 23 antibodies. So this is sort of the next generation of the medication we call ustekinumab or Stelara. And so these are sort of an anti-cytokine medication, and they block this inflammatory pathway, but they do it in even more of a specific way than Stelara does. And so we think that makes them potentially more effective and probably safer. So there are a bunch of these medications in sort of late stage development, which is really exciting. One of them is actually Kizumab is already approved for psoriasis. So it's exciting to have something that's already available on the market. We're seeing how it works and how safe it is. And so this is a really exciting area. The next two categories of medications are actually pills, so that's kind of exciting. The one is a bit of a mouthful, S1P receptor modulators. And essentially what these do is they take active immune cells. Before they go to the gut, they go to the lymph nodes, which is sort of a pit stop on their way to the gut, and they prevent them from getting out of that lymph node so they can't get to the gut and cause inflammation. There are a couple of these in sort of late stage development, ozanimab and etrezimab, and one of them is actually currently available for multiple sclerosis. So these seem to be really effective and sort of a long-term effect and relatively safe. So that's really exciting too, and a pill. The final category of kind of thinking about these as general categories is Janus kinase inhibitors. So these are medications that block a couple inflammatory cytokine pathways at once. So they kind of block this convergence of cytokine signaling. And again, these are pills. There's currently one available on the market called Xeljanz or tofacitinib. And the ones that are now being studied for both ulcerative colitis and Crohn's, because Xeljanz is only available for ulcerative colitis. The new medications are being studied for both UC and Crohn's, and actually are a little more specific. So we think they're kind of probably even safer and hopefully more effective for both Crohn's and UC.
That's great. It's so exciting. And speaking of safety, I know as a patient, the first time you're told you need to try a medication or you're put on a different medication, your biggest concern is what are the side effects? I remember in 2008 when I was lying in a hospital bed after having an abscess the size of a tennis ball in my small intestine and told you need to break out the big guns, you're going on a biologic, and there were only two options. I sat there in my hospital bed crying, Googling, of course, looking at all the side effects of what was available to me. What is being done to make sure that these emerging therapies are safer and have less side effects?
So that's a great question. So, what I sort of mentioned before is that the goal is really to keep on drilling down, making things more and more targeted. So we're only affecting the critical pathways that affect ulcerative colitis and Crohn's disease, without affecting other areas. And so there's a lot of emphasis on kind of making things more effective, but also safer.
And personally, as a patient, luckily for me, I've been able to stay on my injection for nearly 13 years now, but injections aren't for everybody. Some people, of course, prefer infusions. Other people, they don't have a choice. They just have to take the medication that matters to them. And then others just want to be on pills. In your opinion, with these emerging therapies, will it just be infusions and injections still, or will there be more pill options?
Well, I think it's really exciting. As you mentioned, pill or infusions and injections are not for everyone. Infusions and injections in general are a class of medications that we call biologics, and they're somehow derived from organisms, is sort of what that means. They're also in general really big proteins, so unfortunately they have to be given as injections or infusions. And this can lead to some challenges, as some people know we get kind of drug concentrations because people deal with it, their bodies deal with them differently. And there's a lot of variability in that. These have the antibodies, but these can actually be really targeted. So they actually are a great option. But as you mentioned, they're really not for everyone. And so I think the good news is there are more effective medications coming that will be pills. And that's what we call small molecules. And that's, that's what the typical pills people take, like aspirin, high blood pressure medications. Those are small molecules. The no risk of antibodies, a little easier to take, but they also can have side effects. So it's not to say they're necessarily, safer. They're just kind of a different way of giving a medication. But really nice, I think, for everyone to have options.
It sure is. Having options is just so wonderful as a patient, because it's been a long time in this community where we haven't had many options. Now, as a mom of 2 toddlers with 1 on the way, I know most people that are diagnosed are in their childbearing years, and the first thought that they have or their parents have is, will my daughter be able to carry a baby? And it's a very emotional and trying time to think, what does this mean for my future? What does this mean for my health when you receive this diagnosis at a young age? And I think that with these emerging therapies to patients, we have to think about how this correlates over to pregnancy and breastfeeding. And one of the studies right now, called the Piano study, is really paving the way and making beautiful strides for our community. I'm currently registered for it. My baby, my son, will be tracked until he's 18 years old. You fill out different surveys. They look at the cord blood. They look at the breast milk. They track everything to see, when your baby is exposed to a biologic in utero, how is it going to impact development, or anything that congenitally can change? My other 2 children were part of research as well. And I think that as IBD moms and prospective IBD moms, the best thing we can do is participate in research, so we can make a difference for people who are coming down the line wanting to be moms in the future and thinking, if I'm on this drug, will I be able to carry a baby? Will I be able to bring a miracle into this world while on my medication?
Well, I'm so glad you have that perspective and that you are participating in Piano. And I think I would implore everyone out there who's, thinking about getting pregnant to look into it. We have a lot to learn. One challenge with some of these emerging therapies is that we don't have a lot of information about what happens in pregnancy and breastfeeding. And the big challenge is much like the COVID vaccine studies, we exclude pregnant women and lactating women who are breastfeeding from these studies. So it takes us longer to learn about what happens with these medications. So usually we have to wait until the medications are approved and then see what happens in pregnant women. And that's a big challenge. And that's, I think, a big need that the community has, is to really help address that and help make that better. Specifically, it's hard to say about the new therapies where they're going to land, but in general, biologics tend to have be a little more ideal for pregnancy. They, because they are these big molecules, they do not cross the placenta during the first trimester, at least the ones we currently have available, which I think is a really important thing to know. That first trimester is when the main organs are developed, a really critical time in development. And it's always, I think, a little reassuring just to know that they're not going to be crossing the placenta at that time. Similarly, they're really big, so they're really hard to cross into breast milk. So very, very small amounts get into breast milk. So there are really some actually significant potential advantages from these infusions, injectable medications. So, we're really working on this, I think, as a community and really, dependent on women being involved with all this research, but we're trying to find out more. And the good news is most medications that we currently have are safe in pregnancy. And I think that's really, really important to communicate. And the most important thing that we've seen sort of coming out of all these studies, including the recent publication about Piano, and that registry, is that controlling disease seems to be the most important thing. Having a healthy mom with controlled disease leads to healthier babies. And that is, I think, the most important thing to take away.
Absolutely. And the IBD Parenthood Project, created by the AGA in 2019, actually the week that Dr. Boland and I both gave birth to our babies, who are now 2, is a great roadmap and a resource that has different worksheets and guidance for every IBD parent, from the start of family planning to conception to pregnancy and postpartum. So if you haven't done so yet, definitely check it out. And you can even print out the resources and bring them to your OB or your GI throughout your pregnancy. It's a great resource to have. Now, as a physician, Dr. Boland, would you be more apt to put a patient on a current treatment that's available, a current biologic, or an emerging therapy? Is that something that you would consider from the start once it's approved?
That's a great question. And I think it's a really personalized discussion. And I think everyone has a very different take on, particularly my patients, what they would prefer and what they're comfortable with. I think there's a lot to be said for medications that have been around for a long time that we know more about. For some people, that's what they want to, what they're most comfortable taking. Other people think, gosh, there's this new medication, I've read about it, I want to have the latest and the greatest, it seems safer. And so, in that case, I think it's really a discussion just about what we know and what someone's comfort level is. We're working on the learning more, and we do that really through clinical trials. And while it can be hard to know or get into a trial, depending on what kind of trial it is, really, I think it is important to mention them and talk about how it can help make create better therapies for you and people like you. It is a way to get access to novel therapies that are not yet available on the market. You're really kind of being part of science. And I do think there's also something to be said for having a lot of other people watching you. You have a study coordinator, you have a lot of access to your healthcare team. And I think in some ways it ends up, you get extra care. And so for some people, that's really, really nice. It can be hard though to kind of match someone to the right clinical trial. A lot of the trials, especially for kind of these new therapies, have a lot of strict inclusion and exclusion requirements, meaning you have to have the right disease activity, which can be a little complicated. So certainly worth asking your doctor about. And the Crohn's and Colitis Foundation also has a great website that's included here, and I think will be in the chat, that kind of at least lets you peruse and just see what's out there. Because I think it also just provides a lot of hope to know what's there.
On mute there for a second. Gotta love Zoom. I personally have never participated in a clinical trial because I have responded well to my biologic treatment and I've been in remission for 5.5 years, but I am very open to it in the future. If my disease activity were to change, if I needed a different course of treatment, it is a great opportunity for our community to get different answers, different treatments, different therapies, and be a part of research and make a difference. So we are very lucky to have that as an opportunity. Well, thank you so much, Dr. Boland, for sharing these emerging therapies. I think just talking about clinical trials, what's coming down the pipeline and what's ahead is so exciting.
Yeah, no, I think there's a lot of cool things coming and a lot of new approaches that we're exploring in clinical trials. We've had the first head-to-head trial where we've got 2 medications kind of head-to-head recently. There are more coming. It's not going to be every trial, but it's the kind of exciting thing to start seeing. We're incorporating personalized medicine into trials, which really helps us try to figure out kind of the right person for the right drug. And this is really, I think, the way things are going. Some personalized medicine is sort of already being incorporated to some degree. We do certain tests before you start certain medications. We monitor drugs. But I think this will become more and more advanced as we, go through time, as we're going to be able to help figure out, before you start a therapy, I can say, hey, Natalie, this is the right therapy for you, and I think you have a good chance of responding to this, using more than just kind of my experience with these medications, but using, your DNA or your blood cells to kind of help me predict that. So I think this is the way this is going.
That's fantastic and so promising for patients. Really gives us peace of mind. Thanks so much, Dr. Boland. Really appreciate your expertise on this subject today. Well, we're going to move on now to the holistic approach of treating IBD. I'm going to toss it over to Parsa and Dr. Aline Cherabadi.
Thank you, Natalie. My name is Parsa Iran Mahboob. I am a college student at UCLA, as well as a member of the Foundation's National Council of College Leaders, and I am an IBD patient myself. I was diagnosed with Crohn's disease at the age of 8, and I'm excited to spend the next few minutes discussing holistic IBD care with the wonderful Dr. Aline Cherabadi. Dr. Cherabadi, to get us started, we heard some excellent presentations at the Crohn's and Colitis Congress about holistic IBD care on diet, stress, health disparities, and health literacy. Can you explain what it means when we say holistic care, and how does that differ from traditional IBD care?
This is a fantastic time, I think, we're living in how we approach IBD care. I think for the longest time, we were really focusing on IBD as being a GI illness. right? The gut, the number of bowel movement, the diarrhea, etc. But thankfully, and thanks to a lot of work from patient advocate like you and everybody else on the panel, and societies like the AGA and the Crohn's and Colitis Foundation, we're finally looking at IBD in a different ways and understanding that inflammatory bowel disease impact patients at so many levels that are important to look at and improve. And because diet and nutrition are impacted by having a disease, but at the same time, maybe we can help with a disease with diet and nutrition. This is a disease that affects the social well-being, social behavior, being able to have a healthy living. We all talk about living healthy, but if you're feeling ill and cannot exercise, it's very hard to proceed with that. So we're understanding now that IBD impact your sleep quality, your emotional health, your state health. There's pain management being involved, diet that's need to be personalized. So all this now is coming into a picture, and that's what we call a holistic approach. That it's important to look at our patients with IBD, not just as a GI illness, but an illness that can affect different organs outside the GI tract with extraintestinal manifestation, but also affect the different layers of someone's life. And as clinicians, it's important to really look at this and help our patients in the many different components of their IBD care to allow them to be as healthy and feeling as well as possible. So actually, Parsa, I want to ask you what that means for you as a patient, because you heard my version. I would like to hear from you too.
Yeah. So as a patient, to me, holistic care really emphasizes comprehensiveness. It's not, a replacement for traditional IBD care, but it works to really complement your traditional care or even address certain aspects of your health that aren't completely met through just traditional care alone. As a patient, I think holistic care is a vital approach to my health and well-being. And when we talk about well-being, well, I think that really that does not just consist of the level of inflammation in my intestines, but also how I'm feeling physically, mentally, and emotionally. And with a holistic approach, I think we are placing great emphasis on this definition of well-being. And so
I love this answer, and I think you put it right there, that you are a person, not just a GI tract. And I think this holistic approach really improves the patient-physician relationship in being looked at as a whole person and how IBD affect your care. So thank you for this response.
Yeah, no, thank you. And Dr. Cherabati, another area of focus at the Congress was around health literacy and shared decision-making. Why does this matter, and how can it be applied as patients seek a more holistic approach with their GI team?
This is a great question, because one of the first questions my patient asked when we're discussing therapies for inflammatory bowel disease is, what is the risk of this therapy, right? So you're talking to a patient who was just diagnosed with an illness and where therapies have potential side effects. And we're telling our patient, you're going to be on these therapies long-term. So it's absolutely natural to want to understand the risk and to ask the right questions. I think what's very important when we're assessing the risk of treatment is to do it in the right way. So and we'll go over some example later on, but the main key points and main messages I want to leave you with is, when we're assessing the risk of an effective therapy, a therapy that can control your disease, prevent complication, prevent the need to be in the hospital, prevent to need to be on steroids, and we know how much steroids carry risk of side effects. It's important to put that risk of that therapy and compare it to the risk of not treating the disease or under treating the disease or just relying on steroid for symptom control. So it's very important in the discussion you're having with your clinician, with the physician, with the nurses, is to kind of balance out what happens if I don't take this medication versus what are the benefits from this medication and what are the true risks. So this really highlights a conversation between the clinician and the patient in order to be able to empower the patient with all the tools they need to make a decision for their health and which therapy they would like to go for and which therapy is more adapted to their needs and their disease. But also really highlight the importance of physician communicating to the patient the real risk for therapy, the real risk for not treating the disease, and having an open discussion and being open to patient concerns. So for patients, what I recommend is ask the right question, ask the question that you need to really understand what are the risks of a particular therapy. So I want to show you an example with the next slide of how we can really not understand risk properly. And if you're like me and statistics were always bad, you know, in your curriculum, I never understood numbers much. But it's very important when we're talking number and risk to put it in context. So if I say the risk of infection is 3 times higher on this drug than the general population, or the risk of lymphoma is 6 times higher on this drug, that sounds like a lot. And for, you know, as a patient, I would be worried and concerned. So for us as clinician and for you as a patient, it's important to ask the right question and really frame that risk discussion. What is this baseline risk that we're talking about? If the risk is 0.001% of the population and now the risk is 6 times more, it's still a very low risk. And it's important to then put that risk into context. For example, many people worry about the risk of lymphoma. And when we talk about 6 times increased risk of lymphoma, it's important to understand that the baseline risk of lymphoma in the general population in patients with inflammatory bowel disease not on this particular therapy is around 26 per 100,000, meaning if you take 100,000 people, 26 can develop a lymphoma. When you're putting this in context, that 6-time increased risk means 1 person out of 1,000 on this therapy could develop a lymphoma. So it's very important to understand risk. I think we often worry about talking numbers, but understanding where we're starting from the base, what does that increased risk mean, and really having the true risk of the therapy. So I hope I can encourage patients to really ask the right questions here. And, you know, and I wonder, you know, you shared with us that you were diagnosed with inflammatory bowel disease for a long time. And I wonder with you, what are the things that helped you in making these decisions? And then I would love to hear your thoughts about the difference between, you know, a physician telling you need to be on this drug and deal with it versus telling you this other risk, deal with it, versus really having a conversation. That's what we talk about, shared decision making, meaning I give you the tools to make the decision, but we're making the decision together. And our role is an equal role moving forward. I would love to hear your thought, Parsa, and actually give us some tips for patient and clinician, how we can approach these discussion more efficiently.
Yeah, I think it's a great question, especially since I was a pediatric patient, and being a pediatric patient, I think a lot of that control initially goes to your parent and your provider. My 8-year-old self did not think of Crohn's disease as, you know, inflammation in my intestines, but more as, oh, this is just a disease that really makes me want to go to the bathroom. And so I think in the beginning, there's definitely, you know, as a pediatric patient, there's definitely a lot of trust that just needs to be present there, because you might not necessarily have that initial control. But obviously, as I've grown older and when I would occasionally have my flare-ups, yeah, I started to become more involved in the process. I would start, you know, having that conversation with my providers, with my health team. And these conversations, I think what I really appreciate about them is kind of the candidness of my physicians, how they tell me their suggestions, they tell me the benefits, as you mentioned, as well as the risks of their recommendations. And it's, as I mentioned before, kind of this benefit risk analysis. And so just their candidness to answering my questions about, okay, well, you mentioned this risk. Well, what happens if this happens? What happens if I'm on this medication? I think that honesty is really important, and that's something I've really appreciated from my providers.
Absolutely. So if I think the take-home message I get from you is this open communication. Ask the questions. One of the things we struggle with is when patients don't ask questions, they come back home and they're thinking it's true, and that risk is getting amplified, and they talk maybe to family members and they get worried about the therapy. We don't want you to worry alone. We want you to ask us the right questions. All your questions, all the questions are right from the patient, and hopefully we are open enough and give you the right information and the right tools to be able to make these decisions.
Yeah. And so I know one of the other hot topics at the Crohn's Colitis Congress was diet. Can you share some of the highlights of some of the research studies that were presented at the Congress?
Absolutely. We're very excited that we're finally, as researcher and GI community, looking at the impact and the role of diet in inflammatory bowel disease. This is something that have interested patients for a long time. Is what I'm eating influencing my IBD activity? What should I eat? What should I not eat? So the DINE-CD study looked at two diets that are, assessed as healthy diet, the Mediterranean diet and the specific carbohydrate diet. And they looked at both of these diets in patients with Crohn's disease who had mild to moderate symptoms and followed patient for 6 months. And they assessed if the patient felt better, but also they assessed for disease activity. So as you know, Parsa, our goal in taking care of patients with IBD is not only for patients to feel better, but we want to heal the bowel, we want to control the inflammation to prevent long-term complications. And here in the study, one of the things that they use as a marker of inflammation is CRP. CRP is a blood test. I'm sure most of the patients are familiar with that is elevated when, often elevated when there's inflammation, and normalized when the inflammation is controlled, so we can use it as a surrogate marker of inflammation. Both of these diets have particularities, but overall, they favor fruits, vegetables, and legumes and get rid of processed food and added sugar. And they have a different, Mediterranean diet has more of olive oil and fish. The specific carbohydrate diet, you avoid more grains and you avoid some milk product, etc. So they have little differences. And what we see and what the study showed is that actually I think good news in my opinion. One, it shows that most patients with Crohn's disease in the study tolerated both diets well, meaning they tolerated fruits and vegetables and legumes. And I think this is really good news for our patients. Patients also felt better on both diets. So there was symptomatic remission. Patients felt better, their GI symptom was better. And this was independent whether or not patients had inflammation, active inflammation at the beginning of the study. However, what we did not see is a normalization of CRP. So what we don't have yet is whether or not diet can help improve the inflammation in patients with Crohn's disease. So, the way I look at all this data and other data presented about diet is that diet has to be individualized to the patient. Dr. Rubin in his introduction talked a lot about that every patient is unique and every patient is unique in his or her disease, but also in everything else, right? In your needs, in your culture, in your, what you like, in the disease, how it presents, the extent, how it's, whether or not you have complication or surgery. So every patient is unique, and it's important to remember there is no one diet that's going to work for everyone, whether you have IBD or not. So it's important to really personalize the diet, but also it's important to realize that healthy eating is possible in patients with inflammatory bowel disease, the fiber, the fruits and vegetables and legumes, but you need to discuss with your physician, or if you can have access to a dietitian with expertise in IBD, we need to discuss what is the best form of these fibers, fruits and vegetables that are tolerated for you? What are the ones that go with your lifestyle, your culture, and what are the nutrients that you need more of depending on your disease? So diet is what you eat. Nutrients are the benefits you're getting from the diet. And this nutrition has to be balanced so that you don't develop vitamin or mineral deficiency, and that you can be healthy in your body in addition to being healthy in your GI tract. So I think that this is a very exciting time where we're looking at diet, but it's very important to remember there's not one diet that works for everyone. Every diet needs to be individualized, but the good news is you can have a healthy diet. It might need to be adjusted to your needs and your disease and your culture, but you can have a healthy diet that can make you feel better overall.
Thank you, Dr. Cherabaty. We'll talk about a patient's identity. As someone of Middle Eastern descent, I don't know many others of my nationality or ethnicity with IBD. I know other patients from various ethnicities feel the same way. So Dr. Cherabaty, can you shed some light on the impact IBD has on some patients from different racial and ethnic backgrounds?
Thank you, Parsa. This is a great topic of interest. The incidence of IBD has been increasing in the United States in all races. We typically think of inflammatory bowel disease as affecting Caucasian, and you highlight that, and maybe when you were growing up, you didn't have someone else looking like you had the disease, and I'm sure it must have been difficult for you and for your family. I would love to hear your experience later on. But you know, we studied it in medical school as a disease that affects mainly Caucasian and patients of Jewish descent. But now IBD is increasing in all minorities, in African American, in Hispanic, in Southeast Asians, in immigrants to this country. So it's important to recognize that, but also it's important to look at what's going on in these communities. And unfortunately, we're seeing great health disparities in minorities with IBD on multiple levels in terms of utilization of healthcare resources. Many patients from minority end up getting their care from the ER or urgent care or being hospitalized. And as we know, to have good quality continuity of care, it means that we need to be able to provide adequate care for a patient in an outpatient setting so that they don't have to go to the ER or urgent care. So urgent care and ER is always sporadic care that is not optimal when you have a chronic illness like IBD. Unfortunately, there's a high use of steroids, which we know has many side effects and is not an effective therapy to manage inflammatory bowel disease and maintain patients healthy and doing well. There's an increased mortality in minority population who are hospitalized for their inflammatory bowel disease. There's decreased health literacy. This is a new disease in these communities. So again, I'd love to hear your thoughts on this. When it's a new disease and people are not familiar with it, it's very hard to understand the concept and what IBD means and the implication and how important it is to remain on the therapy that can affect that can control the disease. But also we know that African American and Hispanic are often part of have often a low socioeconomic status. And so we can imagine the additional barriers, financial barriers, access to care barriers, access to an IBD specialist barrier that these populations are suffering. If you're I don't need to tell you how much IBD impact all these things, but if you in addition have many barriers to accessing care and a low socioeconomic status that prevents you from reaching quality care. This is really going to impact the overall IBD care in our minorities patients. So thankfully, a lot of societies, including the AGA and the Crohn's and Colitis Foundation, are really looking at changing this at multiple levels in terms of really increasing awareness, increasing awareness about the IBD in minorities, both for patients and for providers and healthcare professional, and really understanding the barriers to care so we can implement strategies to overcome these barriers to care and offer effective and safe therapies and timely therapies to all our patients, whatever their race and ethnicity is. And for patient, I do encourage you to look at the Crohn's and Colitis and AGA efforts, and encourage your physicians taking care of you at looking at whether or not you can be enrolled in a study, in a registry, to really help us understand better how IBD impact minority and how we can better provide better care to our patients with IBD for minorities. So personally, I'm going to stop here, and because I really want to hear your thoughts. I'm Middle Eastern too, and again, growing up and being in med school, I didn't think that IBD is something that would affect part of my family members, and I have family members with IBD. So I really want to hear about your experience and your thought and your suggestions for other patients who are part of a minority where maybe IBD is not a known disease or an accepted disease, or or is still a scary disease.
Yeah, and since we're running short a little bit on time, I'll just mention this really briefly. In the Persian culture, we often emphasize this form of hospitality that really focuses on deference. And so you might go to a relative's house and they are offering you, they keep on pushing you to, their food. And at one point you just have to say, no, if I eat more, it's not going to be good. But also, I think I want to address it through the lens of being a Muslim, and in the Muslim community, a lot of individuals use a lota for hygiene purposes, and for a lot of patients, I think they can attest to how when they're out in the public, they have a lot of anxiety of having an accessible bathroom. But for these individuals who use a lota, there's an additional anxiety of, well, what do I do if I'm in the public because I have no LOTA? And so, Dr. Charbadi, I think if we can spend the next just minute or so on this last topic, but mental health was had a big emphasis at the Congress, and so and it's one that I think a lot of patients can relate to. So, if you could, in 30 seconds or a minute, just really quickly describe the research that's being conducted on the relationship between IBD and patients.
Absolutely. And thank you, Parsa, for sharing with us the challenges of living with IBD within your own culture, within any culture. And I'm sure that affect also stress, that add another layer of stress and can affect your overall mental and emotional health. What we're having from studies is that there is, the study results are a little bit, not going along. The different studies show different results. But there are studies showing that there's a relationship between long-term stress and increased risk of flare inflammatory bowel disease. Some other studies do not show this correlation. And I think the way I interpret this is that every patient is different. And for some patient, emotional stress or physical stress impact their disease differently, same as for some patient, diet impact their disease differently, or other component of their life impact disease differently. But whether stress impacts the risk of having an IBD flare or not, I think it's an important component of your overall health and holistic approach to address. And I encourage patients to have an open conversation with their physician about how IBD is causing stress and impacting their emotional and psychological life. And I encourage all, to have an open conversation so that you can be directed to the right person who can help you. I believe that emotional health is absolutely a crucial component of a holistic IBD approach that should be addressed and taken care of, as well as the physical component. So these are the things that I derived from this, from the results of these studies.
Well, thank you so much, Dr. Charbadi. Unfortunately, this is such a big topic and we have such little time. But thank you for sharing these insights from the Congress. And now it's my pleasure to turn over to Shaylin Feaster and Dr. Jamie Kindukin.
Hi, thank you so much, Parsa. My name is Shaylin Feaster. I'm a native New Yorker, born and raised. I've had IBD for 20 years now. And I am excited to be joined with Dr. Jamie Kindukin from Michigan Medicine for the next part of today's discussion, which is COVID-19 and IBD. This topic was covered by various physicians at the Crohn's and Colitis Congress, including Drs. Ongaro and Dr. Brenner. Dr. Ongaro was my doctor a few years ago. Having been in New York City through the pandemic, I've had my own concerns about my disease and if COVID-19 may put me at a greater risk for contracting the virus. So with that being said, Dr. Kindukin, what are some of the risk factors for COVID-19, and are IBD patients at greater risk for contracting COVID-19? Also, does having IBD put patients at risk for worse outcomes if they do contract COVID-19?
Shaylin, that is a great question to start this very important discussion today. And I've been following along on the Q&A from our participants today, and there's been many questions coming in related to COVID-19 and IBD. I want to thank the Crohn's and Colitis Foundation. I want to thank my colleagues, as well as all of our patient advocates, for helping us put this program together today. I know that the questions that you're asking weigh heavily on our IBD patients. However, the answer, I feel, is reassuring. Most patients with inflammatory bowel disease are at the same risk as the general population for SARS-CoV-2 infection. This is despite, one, being diagnosed with inflammatory bowel disease, which is an immune-mediated condition, and two, many of the medical therapies that we use that can be immune-modifying type treatments. The other questions that you asked were some of the risk factors. If you look at the slide that we put together today, some of the risk factors that we see in IBD patients for worse outcomes associated with COVID-19 are similar to that of the general population. Things like asthma, hypertension, obesity, diabetes, and kidney disease. The presence of 2 or 3 of these increases that risk further. What has been seen related to IBD patients is that in the studies, those that were older, had active disease, or were currently taking steroids had the highest risk for poor outcomes associated with the SARS-CoV-2 infection.
Thank you. Okay, so let's talk about some patients that do have some GI issues. I know COVID positive patients can have some GI issues like nausea and diarrhea. How can patients tell a difference between GI issues related to COVID-19 and an actual flare-up?
That's a great question. And when we think about COVID-19, when it was first described almost a year ago now, the focus was on respiratory related symptoms and fever. However, we've come to learn a lot over the last year. And since the start of the pandemic, we know that people that are infected with SARS-CoV-2 or COVID-19 infection can present with a variety of symptoms. This data that you can see on the slide comes from a study that actually looked at the most common presenting symptoms in a group of IBD patients diagnosed with COVID-19. As you can see, the top three were fever, cough, which is what we thought, but then the third one was diarrhea. You can see that 8 to 20% of patients will experience symptoms that can mimic IBD relapse or flare. And things like diarrhea, nausea, abdominal pain, and vomiting. Many of our listeners, and I'm sure Shaylin, as you as well, can relate to that. So it's important that you recognize that if you have a change in your symptoms from where your baseline is, that you need to contact your healthcare team to consider being tested for COVID-19. Most IBD patients actually know what a typical relapse or a flare feels like for them. And so that history is so important to be able to provide to your healthcare team to help them as part of your initial evaluation for some of these GI-related symptoms.
Thank you, Dr. Kanukin. And can we talk a little bit about COVID-19 and IBD medications? Do any of the drugs used to treat IBD have an impact on outcomes if you have COVID-19?
That's a great question. Shaylin, you're touching on all the high yield things that are being asked by our participants. This is probably one of the most common questions that I've been asked most recently. And luckily, we have excellent researchers throughout the country who partnered together to create the Secure Ibd Registry. And as you can see at the bottom of the slide, the actual website is listed right there. We can also send it through the Q&A function as well. This is an international registry that right now has over 4,000 IBD patients who've been positive for COVID-19. The purpose of this registry was to assess IBD patient outcomes after infection for those patients that were on either no medical therapy or various medical therapies that we use to treat inflammatory bowel disease. This slide is a really high-level overview about what was found. I'm not going to go necessarily into the specifics of the data, but overall what they found was that anti-TNF monotherapy. So for those of you in the audience, this is the infliximab, adalimumab, certolizumab, and golimumab. They found that anti-TNF monotherapy might possibly be protective. And so we certainly know that it does not increase the risk for severe outcomes associated with COVID-19 infection. In addition, non-TNF biologics like vedolizumab or ustekinumab also showed no increased risk. There is a possible association with patients who are taking mesalamine therapy. These are pill-based therapies often used in ulcerative colitis. However, there's some controversy as to why we're seeing this signal, and it's possible that these patients are undertreated for their disease, and so we're seeing the active disease putting them at risk for severe outcomes or more severe outcomes with COVID-19, because these therapies don't alter the patient's immune response. We really do need more follow-up on this, as this signal is very, very small, but something that we did see in the data. And then we also see that there has been an association with some of the therapies for an increased risk for severe outcomes with COVID-19. There was an increased risk for those patients taking combination therapy, which many of our patients and many of the people listening today are on anti-TNF combination therapy with an immunomodulator, whether that's methotrexate or Imuran or azathioprine or 6-mercaptopurine. In addition, even in the absence of an anti-TNF, those patients on thiopurine monotherapy, Imuran, azathioprine, 6-mercaptopurine, did have an increased risk for COVID-19 complications. But what we see as the highest risk by far, but beyond any of the therapies that I just mentioned, is the use of corticosteroids or steroids. So what I can stress is that all IBD patients should stay on their current medical therapy as prescribed. Being in remission is probably the most important thing that you can do to limit your risk for poor outcomes, including avoiding steroids, hospitalization, which is the top priority right now in this pandemic. But if you do have concerns about the medical therapies that you're on and their potential increased risk for COVID-19 outcomes, I think you need to work with your healthcare team and develop a plan that makes the most sense for you to minimize your risk for both disease relapse as well as minimize your risk for complications associated with COVID-19.
Thank you, Dr. Kanukin. So I just want to just be clear and make sure. So if an IBD patient tests positive for COVID-19, should they continue on their prescribed medication?
Those are great questions. And while we like to approach this very similarly for all patients, we treat patients, very differently in terms of their disease and what their risks are. And so while it's hard to give you a blanket answer, this was something that was recently presented at the Congress. It also has been supplemented by expert opinion through the international organization IBD. So if you're an asymptomatic carrier, meaning you got tested because of an exposure, you can see the second arrow in the blue. You need to work with your healthcare team to find out if it's right for you to hold your therapy for 10 days. And if you don't develop symptoms within those 10 days, to resume your medical therapy for inflammatory bowel disease. However, if you test positive and you have symptoms, whether they're mild, moderate, or severe, the current recommendations are to withhold therapy until you enter the recovery phase, which is the last arrow here, which is where you can resume therapy. Of course, at the direction and approval of your healthcare team, depending on how severe your episode of COVID-19 was. Again, each patient will need to individualize this plan with their healthcare provider. I do not want patients to take away that they should be stopping their therapy without working with their healthcare team. This could result in a relapse, the need for steroids, which we know again is the highest risk for poor outcomes associated with COVID-19, hospitalization, or surgery, all things that we're trying to avoid. I actually have a couple questions for you, if you don't mind.
Sure.
I do know that this pandemic has been stressful for patients, and I wanted to ask you, what measures have you been doing to stay safe?
So to stay safe, I make sure to first keep my doctor's appointments. After determining whether that doctor's appointment can be done via telemedicine or if I have to come in, I keep my appointments. I stay connected with my friends through virtual apps. And I also make sure to keep my therapy appointments as well to maintain my mental health. So I just make sure that I'm staying connected through family and friends. And I also make sure that I keep my doctor's appointments. I also, of course, make sure I social distance and wear a mask and, and don't socialize in person too much.
Great. And I understand, those are all great measures and things that I think that my colleagues and I all recommend when we're seeing patients in person. I understand that you were also hospitalized a lot and a few times for your disease, and maybe most recently in the last year. What was it like to be hospitalized during a pandemic?
Yeah, so unfortunately, I was hospitalized about 4 times since October of 2020. So it was a bit scary because you don't know what you're coming into when you come into the emergency room. But I can say that I felt really safe because they do have measures in place at this time because of COVID-19, some special measures. So for example, you come into the emergency room, you are tested for COVID-19 within a few hours. That's after they assess your pain level and assess the issue that you're having. You are tested for COVID-19. This lets the team know how much PPE, the staff should be wearing when they're talking to you as a patient. So it protects the doctors and the nurses after you're given a COVID-19 test. And if the results determine that you're negative, you're put into a room. You may have a roommate who's also negative, or you may have, if they have the capacity, you may have a single room as well. But I can say that I was treated well for my IBD. Another measure that they put in place is that they limit the amount of visitors now, the visiting hours. So there has been some changes to maintain the safety from COVID-19, but I did feel that my IBD was treated. So, I was not happy to be in a hospital, but I'm happy that it turned out well.
I'm glad that you're doing better and you're able to join us today. I want to stress the importance of if you need to be seen, don't avoid the hospital. If you need to be seen by your provider, we have special clinics, at least at University of Michigan, where I reserve space for face-to-face patients, but we are learning to adapt in that virtual world. But when we need to see you in person, it's for a reason, and we'll do all the things that we can to protect both our patients and us as providers too. So great questions.
I completely agree. So just moving along a little bit, according to the news earlier this week, the US has delivered over 22 million doses of the COVID-19 vaccine. So that begs the question that I know a lot of other patients have as well. Is it safe for IBD patients to get the COVID-19 vaccine? And what are some common side effects of the vaccine?
Great questions. And I saw in the chat over the last hour, lots of questions coming in related to the COVID-19 vaccine, just in general, but then of course, being an IBD specific discussion today, we're going to really focus on things that we know related to COVID-19 and IBD vaccination. So right now there are 2 FDA approved vaccines from Pfizer and Moderna that are available through the United States Emergency Use Authorization, or EUA. We do believe that both of these vaccines are safe in patients with IBD on any type of medical therapy. The common side effects that you can see listed that we can expect patients to have, which essentially means that your immune system is doing something to create an antibody for immunity. It includes injection site reaction, fatigue, headaches, chills, fever, joint and muscle pain. As someone that's been vaccinated, I can tell you I did experience some of these and they were very mild and they go away, they're temporary. I think it's important that we as providers and as patient advocates educate the public as well as our IBD patients that they should expect these possible side effects. It's an indication, again, that the immune system is working, and to remember that these side effects are temporary and mild compared to a primary infection with COVID-19.
Thank you. So should we be concerned about the vaccine causing a flare-up or any long-term issues, especially those of us who may be on immunosuppressant therapies?
Other great question. So I'm just going to review a little bit about the vaccine and the technology itself. The current approved vaccines use the mRNA technology, and there will be other vaccines that are going to be coming through in the approval process in the coming months that will have a different type of technology, but I'm going to focus on the technology that's currently available to the public as well as IBD patients. These are non-live vaccines. We don't have any additional safety concerns about these vaccines in IBD patients other than what was listed in the clinical trials. So the issue is that our patients haven't been studied in the clinical trials. IBD patients and patients on immune modifying therapies were not included in the clinical trials for both Moderna and Pfizer. We do believe that these live vaccines, these non-live vaccines, my apologies, and definitely a misstep, will not result in an increased risk for disease relapse. We can say this not because we know a lot from patients with IBD being vaccinated, but because we have a lot of data in previous vaccines that while they weren't the same technology, were also non-live vaccines, also very potent immune stimulating type vaccinations that have not resulted in disease relapse. So it is not a concern at this time that we would expect patients' disease to get worse on these vaccinations.
Okay, thank you. And were IBD patients studied in the clinical trials for Pfizer and Moderna vaccination?
No, and I think I touched on that briefly, is that unfortunately IBD patients, just like rheumatoid arthritis patients and lupus patients, were not included in the clinical trials for Pfizer and Moderna. That's pretty standard to leave patients out that have immune-mediated conditions as well as being on immune-modifying therapies to try to expedite the approval of these vaccinations. And eventually patients are studied with these vaccines, but they're typically after the initial approval process. Again, we make these conclusions based on what we know about other vaccine data in patients with inflammatory bowel disease. Bottom line, these vaccines are safe. The only concern that we have is whether or not they will have the same effectiveness in patients with IBD, especially patients taking corticosteroids. So we don't necessarily believe that the effectiveness will be significantly reduced with other immune modifying therapies. However, with corticosteroids, we know that this can have an impact in terms of the effectiveness of vaccines, although it's not going to take it to zero. And if we have patients that are on steroids, which again is the highest risk for worse outcomes, we do want to get them vaccinated, and it's probably getting you on the lowest dose of steroid to get you vaccinated as possible. The one other thing, I was just going to talk in terms of the timing of medications. Some patients have asked about when they should get their vaccine if they're on a biologic therapy. And while we don't believe that the vaccine effectiveness will change based on when you get it associated with your biologic therapy, I personally have been recommending patients to avoid getting it within 24 hours of each other, mainly so that we can, if there's a possible reaction to the medicine or a reaction to the vaccine, we can try to determine either one of those. And then lastly, I think we're going to touch on a question that has come up in the Q&A. We are planning on studying patients with IBD and looking at how they do with the vaccine. So beginning in February, the Crohn's and Colitis Foundation, through our IBD Partners National Registry, will be looking at IBD patients who've received the COVID-19 vaccine, and to be able to better inform some of these really important questions that you're asking.
I so appreciate you for expanding on that. So if a patient has had allergy or anaphylaxis to IBD medications or other vaccinations, is it safe to get the COVID-19 vaccination? And what about people who are pregnant and managing their IBD?
Well, first I'll touch on the previous reactions in anaphylaxis. I know that there can be a lot of anxiety in patients who previously had an allergy or anaphylaxis to either medications or other vaccines. Ultimately, we believe that the COVID-19 vaccine should be safe for almost all patients, with rare exceptions. If you've had an allergic reaction in the past to either medications, including your biologics, or other vaccinations, they'll likely ask you to stay and be monitored for up to 30 minutes instead of the standard 15 minutes for those patients that don't have that higher risk for a reaction. If you still have concerns about your particular individual risk to a reaction to a COVID-19 vaccine, I recommend that you work closely with your primary care provider to find out if there is an absolute contraindication for you to receive the vaccine. Then touching on the next question that you asked, which I think is something that also has been asked throughout the Q&A today, is those that are interested in pregnancy and those people that are currently pregnant or expecting mothers have been very anxious about COVID-19 in general, as well as the lack of data that we have in pregnant women receiving a COVID-19 vaccine. In general, we know that pregnancy can increase the risk for poor outcomes associated with COVID-19. That seems to be in the later trimesters than necessarily earlier in the disease. However, the Secure Ibd Registry, which looks specifically at IBD patients, have not found any specific findings associated with COVID-19 in pregnancy in IBD patients, and we're continuing to follow those patients throughout the registry. The general recommendations that come from the American College of Obstetrics and Gynecologists are that women should have access, pregnant women should have access to the COVID-19 vaccine, as well as lactating women as part of the priority groups, which we'll touch on a little bit in a couple minutes. It is important that you partner with your OB provider as well as your high-risk OB provider, which many of our patients are probably seeing, to make the decision that's best for you and your baby. I am currently recommending vaccination for my pregnant IBD patients.
That's great advice. And my final question is one I'm sure a lot of other patients are wondering about. When will I, as an IBD patient, be eligible to get a vaccine? Is it a priority?
Shaylin, you're asking the same questions that all of my patients this week were asking is, okay, Dr. Kanukin, you've convinced me it's safe. I want to get the vaccine. How and when can I get the vaccine? The issue is that we're currently in a state where there are limitations for vaccine access. And so the supply issues that are happening at a state level is what's going to ultimately limit our ability to roll this out to more of the general population, as well as our IBD patients at risk. We are hoping that this is going to improve in the coming months with purchase of more vaccine, as well as hopefully approval in the coming months of another vaccine so that we can improve access. However, patients are grouped based on the CDC and ACIP into priority groups, and that is actually based on state and local health departments. So some take-homes from a recent paper that was published, expert opinion from the IO-IBD group, again, is that IBD patients should get vaccinated when they have access and they're able. How do you qualify IBD patients? Patients with IBD on immune-modifying therapies, so many of the medications that we give should be classified as immunocompromised. And so that definition will fall on basically a state-local level. The tier or phase that you qualify for, again, is going to be determined based on where you live and your local health department. So it's going to be really important to know what your state is doing and how it's classified, because it's actually very different between Michigan and Ohio and Chicago or Illinois and some of the surrounding states. Even around us, it can vary. The most important thing, and you mentioned this before, Shaylin, which is so important, is that even if you do receive the vaccine, it's important to still follow the CDC guidance, wearing masks, social distancing, avoiding in-person gatherings. Being vaccinated does not mean that you cannot become infected with COVID-19. Being vaccinated means that it reduces your risk for severe COVID-19, hospitalization, and death. And in some of the vaccination trials, to almost zero. So what's really important is that we still all do our part, even if we're vaccinated. It is not a free pass to start going back to things pre-pandemic.
Awesome. Thank you so much, Dr. Kanukin, for sharing all this very important information with us today. So it's now my pleasure to turn it over to Rebecca Kaplan from the Crohn's and Colitis Foundation, who will lead us through a final Q&A for today's program.
Thank you so much, Shaylin. I'm going to invite all of the speakers to come back on screen so we can do a Brady Bunch style rapid fire Q&A. Well, thank you to everybody who has been listening for the past hour or so. We're really excited that you joined us on a Saturday to hear such important information from our speakers. As Shaylin said, my name is Rebecca Kaplan. I'm the Associate Director of Marketing and Communications for the Crohn's and Colitis Foundation. We got over 400 questions from you guys during this chat, and I don't think we're going to be able to get to them over the next 7 minutes, but I did pick some of the most commonly asked ones that I think are important that we address now. So the first one is, and I'm going to throw this over to you, Dr. Charabati, is do you think support from a dietitian would be beneficial for IBD patients?
Absolutely. I think the dietitian plays a major role in taking care of patients with IBD for 2 reasons. One is if the patient has any nutrient or vitamin deficiency, whether because the small bowel is involved, or there been a resection of the small bowel, or there's certain food group that the patient is not tolerating because of the disease or something else. It's important to work with a dietitian to find food groups or determine what kind of supplement the patient needs. But also there is such a confusion about diet and what a good diet is in patients with inflammatory bowel disease that often what I see in my patient is that extreme restriction of many food groups that really turn food into the enemy. And part of having a holistic approach to IBD, healthy and a good life with IBD is to be able to enjoy the food and to be able for our patient to go out with their friends and family member and have a gathering and still find enjoyment in this. So I think working with a dietitian is very important to find which food groups are, what can you switch for what, and to be able to have a good nutrition, but also to adjust the diet to your needs and to your personal needs, physical need in terms of your disease and your cultural need and a healthy social life. So unfortunately, there's not always a good access to a dietitian with expertise with IBD. So hopefully we see this changing and better access and better coverage for a dietitian.
Wonderful. Thank you so much, Dr. Charabati. So we talked a lot about, different things related to working with doctors and becoming an effective partner in your care. Dr. Jane, do you have suggestions for patients who want to speak with their doctor when their colonoscopy shows that they're in remission, but they're still having symptoms?
Rebecca, that's a great question and issue. As I mentioned before, often there's a disconnection between symptoms and what the lining of the colon or gut looks like. So many times in patients with inflammatory bowel disease, they may have overlap of irritable bowel syndrome symptoms as well. So one thing we need to also remember is you now have a sensitized digestive tract. You may have other things going on. We were just talking about dietitian. Could you have some components of lactose intolerance, for example, as causing digestive symptoms? So it is important to assess that the gut is in remission. And then if you're still having symptoms, to look for other potential causes that could be then addressed and alleviated.
Wonderful. Thank you so much. So I think we probably have time for one more question. Unfortunately, I know there were a lot of them, and we will be developing an FAQ document based on the most commonly asked questions from today. But I do want to throw this out to everybody, and we'll kind of do it round robin style very quickly. For the newly diagnosed patients and their caregivers who are watching right now, what advice do you have for them as they move along in their IBD journey? And I think, Natalie, do you want to kick it off?
Sure will. So my heart always goes out to the newly diagnosed patients and the parents and the caregivers. The first year is truly the hardest of the entire patient journey. So I want you to be patient with yourself. I want you to know that you were just given a diagnosis for which there is no cure, and it is incredibly overwhelming. It's okay to cry, it's okay to hurt, but also understand that I believe that those tough moments, they really give you perspective and gratitude for a feel-good day. And it's not always going to be doom and gloom. You can still achieve your dreams. You can still go after that career. You can still find love. You can still be a mom or a dad. Don't allow this disease to rob you of your dreams or change the person that you are. It does not need to change your identity. It's not a scarlet letter. It's nothing to be ashamed of. You are not a burden. You're still the same person. Your life is just going to take some different detours, highs and lows. It's a roller coaster. Ride those highs and you'll get through those lows, and it'll change you for the better.
Parsa, do you want to go next?
Yeah, the biggest advice I can give anyone, honestly, is to find a support network, is to find a community, is to find that shared experience. The best skill, in my opinion, is to be able to find resources. As a patient, you won't know the answer to everything. You'll need to seek help. And you need to know how to find the help, how to find these resources, and a community, a shared community can be very helpful for that.
Shaylin?
Thank you. I want to say when you're going to be presented with a lot of information when you go to the doctors. Make sure you're writing things down. Make sure that you find support, as Parsa said, and know that, be prepared that not everyone in your life will be supportive. Lean on the ones that are supportive. Find a good mental health therapist and find a good outlet for you, whether that's journal writing, some type of creative art projects, or the arts. Find your outlet.
Dr. Boland?
I really like the idea of just really finding some way to connect to at least someone who's been through the process. I think that can really help. And just continuing to be your own best advocate. You're going to keep advocating for yourself and speak up when things aren't right.
Dr. Jane?
Those are terrific comments from everybody. From a provider perspective, I would say, just get all your information together so that we can help you be the best person you want to be and get your disease under control so that you have that fulfilling life.
Dr. Knukin?
It's hard to tap the patient perspective in this, but one of the things that I always do at the beginning of a visit is ask what the goals are. So be comfortable expressing what those goals are, and it may take some time to develop that relationship with your provider. But if your goals are to get pregnant in the next year, let me know that, because it may change the way that we approach your care. And so make sure you express your goals. And if your goals are just to be able to go out to dinner and eat at a restaurant, that's okay too. We just want to make sure that we're on the same page. So I loved all the comments. That would be the only thing I can add.
All right, then Dr. Charavati.
I really loved all the comments, and I think IBD can be a very isolating disease. So I think what I get from most of our patient advocate is find your tribe, find your, you're not alone in this. There are others who've been through this who can, share their wisdoms. The Crohn's and Colitis Foundation is here, the AGA is here, patient advocates are here. Find your local chapter type connection, but also connect with your physician. We're not only here to take care of your GI tract, we really want the best for you. And I think an open communication is key. Tell us, ask us your questions, your doubts, your concerns, your worries. I'd rather you ask me what's going on than go Google and just get into that anxiety mode. So ask your question, be open about what's important for you. What are you concerned? What are your goals, like Jamie said? But also how IBD is affecting your life. That helps us understand what's going on in your life and put things into context. And I think developing this relationship with your medical team is key because it's true partnership for long term. So find the right partners for you. And there's not one perfect answer. We all have people who like us and don't like us. Find what works for you, the style that works for you, and the place where you feel comfortable connecting, discussing your issue, asking your questions, and feel understood and heard.
Great, thank you so much. Natalie, I'm going to turn it over to you to close it out for us.
All right, thank you so much, everybody, for tuning in this morning, this afternoon, whatever time zone you're in. It's been such a great discussion, so informative and so beneficial from a patient perspective, just to hear on all these topics. Even though I'm almost 16 years in my patient journey, I know I learned a lot. And of course, we had so many questions. Do not fear if yours did not get answered. There will be a Q&A document available within the next week from the program that you can find on the IBD Help Center on the Crohn's and Colitis Foundation website. We just want to thank again Bristol Myers Squibb for supporting the IBD Insider program and making it possible today. And also be sure to complete your program evaluation so we can improve the program in the future moving forward. And I just want to close with a few last remarks. The IBD family is resilient, we're strong, and we are supportive of one another. And when I was diagnosed in 2005, I felt like I was on a desert island because I didn't know one other person with IBD. Now in 2021, we have social media, we have blogs. There's a huge IBD family and community right at your fingertips, especially in the pandemic. Take advantage of it. Don't feel so isolated and alone in your journey because we are all here. We all have unique experiences, but much of the same. So if you're sitting there alone in your bathroom crying, or if you're in that hospital bed alone listening to those machines beeping in the middle of the night and you think nobody is going through what I'm going through, just know there are millions of people and we are fighting for a cure. And this IBD family is going to get through this. So reach out, never hesitate to send a direct message or reach out on Instagram or send a tweet. It is not annoying. It is not an inconvenience. As advocates, we are out there because we care, and we're out there because we've been in your shoes. We've been on steroids. We've been on biologics. We've done these things, and we want to help you navigate these difficult ups and downs, and your providers are there with you every step of the way as well. And we're so lucky to have so many physicians that are in our corner and that genuinely care about our well-being. So I get emotional because I was diagnosed at 21. I wasn't sure what my future would hold. And despite having my illness, people always say, Natalie, would you give up your Crohn's? And I say no, because it made me the person I am today. And it's guided so many decisions and so many choices. And it's almost a badge of honor to accomplish things in life that may be basic to somebody, but you get up every day. You might be fatigued, you might be tired, you might be flaring, but you do it. You get through the day. So I just want to commend you for your bravery and your resilience, and know that we are all here for you. We'll get through this pandemic. And I just want you to stay well and stay strong. Thanks so much.